Pharmacology of the respiratory system, e-learning lecture, oxygen therapy. The learning objectives for this lecture is that we are going to, the students at the end of the lecture has to know the indications for the use of oxygen therapy. What are the potential complications, side effects of oxygen therapy, toxicity? Number 3, identifying the signs and symptoms of oxygen toxicity and identifying various methods of oxygen delivery for therapy. This includes also ways for humidification of the delivered oxygen, the long-term oxygen therapy, and hyperbaric oxygen therapy. Oxygen in our environment, as we all know, it is widely available in the atmospheric air, but when it is prescribed and administered correctly, it can be life-saving, and here it's considered as a drug and not just merely an inspired air. The normal daytime hemoglobin blood saturation of oxygen is 96 to 98%. That's in young adults when they are at the sea level. But the lower limit, which is 96%, can fall slightly with the age and reaches about 95% in adults who are above the age of 70 years old, or also can fall in individuals who are living in high altitudes where the partial pressure of oxygen is less. So how much oxygen is available in the atmospheric air and the room air? The oxygen, as we all know, it comprises 21% of the total atmospheric air constituents. CO2 is less than 0.05%, and nitrogen constitutes the majority of 79%. Now, if a partial pressure of a person or a patient has dropped to lower than 96%, let's say reaches 90%, on the normal air, and then we started to administer a concentration of oxygen at a fractional inspired oxygen concentration of 28%, then we expect the partial pressure saturation or the saturation pulse oximetry reading to increase by 7%, which is the difference between the atmospheric air level, where the partial pressure of the oxygen in the blood was only 90%, and by adding 7% with the fractional inspired oxygen, we expect a 7% increase. We expect a 7% increase from 21 to 28. So the saturation might be seen to increase to level of 97%. And that is generally, or roughly speaking, the way of how to choose the concentration for oxygen delivery. Now, what happens to the body when there is hypoxemia? So first, let's know what is the definition of hypoxemia. Hypoxemia is a fall in oxygen concentration of the blood, and then it becomes less than 90% saturation with oxygen. So the normal saturation of oxygen is for the partial oxygen pressure is 80 to 100 millimeter mercury. Okay, and this corresponds from 100 to 80 partial pressure in millimeter mercury. It is expected to have a percentage saturation for the hemoglobin of more than 94%, which is the lower limit, as we have mentioned before. Now, if the partial pressure of oxygen falls to 60 to below 80, 60 to 80%, then the patient will start to have this is a hypoxemia. So this hypoxemia will be characterized by cold, clammy extremities, and if further fall in the partial pressure of oxygen in the blood, then the patient might suffer from cyanosis, which is dusky bluish discoloration of the skin and mucous membrane, and there might be also cardiac and CNS dysfunction. For a partial pressure when it falls to less than 40 millimeter mercury, which corresponds to saturation of less than 75% of the blood oxygen level, then we expect more severe mental deficiency, seizures, and memory loss. For the partial pressure of oxygen falling below 30 millimeter mercury, we expect even bradycardia and cardiac arrest, and this corresponds to um, the percentage saturation of hemoglobin to 57 and less. So the cutoff line below which the saturation falls is 90%, where becomes an absolute indication for oxygen therapy. And this corresponds to a partial pressure of oxygen of 60 millimeter mercury. So at this level, it will become an absolute indication for treating that patient with oxygen as a drug in an oxygen therapy. Now, how do we identify the blood saturation with oxygen or the partial pressure of oxygen? We have two main investigational strategies. The first, the pulse, is the non-invasive pulse oximetry. This is the device which is connected to the measuring device connected to the cord cable that will be clipped to the fingertips, or it can be clipped, also applied to the earlobes or the nasal bridge. Okay, but the most common is the fingertip, and it measures the saturation, that gives a rough estimation of saturation of oxygen in the blood. It is considered as not accurate if the partial pressure of oxygen falls below 60 millimeter mercury. So the accuracy becomes less. The reliability of the reading for pulse oximetry is poor in cases of poor perfusion, in case of cold extremities and cold digits, and in case of nail polish application. So what is the more accurate way for measuring the partial pressure and the saturation of oxygen? The most accurate way is by arterial blood gas analysis, which is taken from the arterial blood. From the arterial blood, can be from the radial uh, artery, and it gives, although it is in an invasive way, considered as an invasive way, but it gives a direct measure of the partial pressure of oxygen, which, as we said, the normal is 80 to 100, which corresponds to more than 90%, corresponds to more than 94% uh, of hemoglobin saturation. Yes, 95 to 100% of oxygen saturation. Although this is an invasive way, but it is more accurate and can be used for critically ill patients. So this is the difference, comparison between arterial blood gas analysis as compared to pulse oximetry readings. For the saturation for measuring the partial pressure of oxygen using the arterial blood gas analysis, as I said, although it is an invasive blood test, it measures all oxygen molecules, the free and also the unbound, or the unbound free or the unbound oxygen, as well as the partial pressure of oxygen that is attached to hemoglobin. It is an indication of tissue perfusion, gives an indication of tissue perfusion, While for pulse oximetry, although it's non-invasive, but it only indicates, or it points out the percentage of bound hemoglobin and not the free hemoglobin. It measures the blood saturation. It does not measure the tissue perfusion. Okay, and then the action should be taken, as we mentioned, uh, when the pulse oximetry reading of oxygen saturation reaches below 90%. While for partial pressure of oxygen, the action should be by giving oxygen therapy if the oxygen um, partial pressure falls below 60 millimeter mercury. So what are the indications for oxygen therapy? One of the learning objectives of this lecture, oxygen therapy given as a treatment of hypoxemia, which is low oxygen saturation in the blood, and it is not given for breathlessness. So even in the absence of breathlessness, or dyspnea or difficulty in breathing, but the oxygen saturation is less than 90%, then this is an absolute indication for oxygen therapy. On the other hand, in some other patients who are having dyspnea or breathless for many other reasons, psychological or any other cardiac breathlessness, but the oxygen saturation is still normal above 95%, then this breathlessness is not an indication. That means that what matters here is the level of oxygen and not the mere clinical breathlessness that the patient can suffer from. The aim is to achieve normal or near normal oxygen saturation for all acutely ill patients. Oxygen should be prescribed to achieve a target saturation of 94 to 98% for the most acutely ill patients. For the chronic patients who are suffering from diseases that lowers the oxygen saturation in the blood, then uh, the target saturation should be around 92 uh, for those who are at risk of hypercapnic respiratory failure, which is type 2. Now, when do we give? When do we deliver? When do we administer? When do we start therapy? Is when there is a documented hypoxemia, evidenced by the partial pressure of oxygen less than 60 or the saturation less than 90 on room air with or without breathlessness. Partial pressure or saturation of oxygen below the desirable range for specific clinical situations. In acute care situations, also, we need to deliver oxygen in which hypoxemia is suspected, like such as severe trauma, and in cases of severe acute asthma, what's called status asthmaticus, then oxygen here can be or will be indicated. And acute myocardial infarction is another indication for oxygen therapy. Short-term therapy for post-anesthetic or post-operative recovery period. The aim, as we said, is to achieve a target saturation of above 95% in most acutely ill patients or 92% for those who are at risk of respiratory failure type 2. Now, what are the types of respiratory failures to which certain differences in oxygen therapy will be administered? So for type 1, in which there is no hypercapnia, there is only hypoxemia, we can find that the saturation of oxygen is less than 90%, or the partial pressure is less than 60 millimeter mercury. And here, in such cases, these are acute illnesses, usually acute illnesses, and not chronic illnesses like COPD. So here in acute illnesses, high concentration for a short period of time without the need of artificial ventilation is administered. Yes, such as status asthmaticus, like in myocardial infarction. So these are acute illnesses, acute situations in which the oxygen saturation falls without hypercapnia, without a rise in carbon dioxide. Now for type 2, which is called hypercapnic respiratory failure, there is a rise in the partial pressure of carbon dioxide above 50 millimeter mercury with or without severe hypoxemia. So on type 2 depends mainly on hypercapnia, while for type 1 it is only hypoxemia without hypercapnia. And when there is an increase in the partial pressure of CO2, of course, it will be associated with metabolic or respiratory acidosis, in which the pH will fall below the neutral pH, below the lower limit of the neutral pH, 7.35. And here, the treatment should be with low concentration for intermediate periods of times, and sometimes with the need of artificial ventilation to prevent the respiratory center depression. So here, the low concentration of oxygen therapy should be administered, but for a bit longer periods of time. And the reason for that is that we do not want to have a respiratory center depression if we give high oxygen therapy, high concentration oxygen therapy. So hypoxemia due to hypoventilation after narcotic overdose is another indication. Narcotic overdose like morphine, meperidine, heroin, all these are characterized by hypoventilation as a toxic side effect of narcotic overdose. And then the patient remains at risk of respiratory failure if ventilation is not increased or not stimulated, or there is no narcotic reversal or mechanical ventilation. Still, the patient will be under the risk of respiratory failure, type 1 respiratory failure. For severe acute asthma, nasal cannula or face mask can be used to give a flow rate of 4 to 6 liters per minute to achieve a fractional inspired oxygen of concentration of 35 to 40%. If another indication for oxygen therapy, if there is an intravascular air embolism, there is pneumothorax. Yes. 100% oxygen concentration can rapidly denitrifies the gas-filled spaces, and therefore this is the benefit of giving oxygen therapy in pneumothorax, because it will denitrify and remove the nitrogen. Denitrifies means remove the nitrogen from the gas-filled spaces, and lowers the total body partial pressure of nitrogen with that. And this provides a substantial gradient for the removal of nitrogen, which then ultimately is absorbed to the circulation. So this should be tried should not be tried for more than 12 to 16 hours to avoid oxygen toxicity, because of the very high of oxygen as a drug. In case of decompensation sickness, oxygen therapy will prevent bubble formation in the blood. In patients with elevated pulmonary arterial pressure, living at high altitudes, usually those will be patients who are having chronic hypoxemic pulmonary hypertension. This will reverse the oxygen therapy or return this pulmonary hypertension will be reversed with oxygen therapy, or it will be reversed by returning to the sea level lifestyle. Neonates with congenital heart disease will also benefit from oxygen supply or oxygen therapy. Severe cases of pneumonia with a low rate of 46 liters per minute of the oxygen delivery rate, flow rate of 46 liters per minute to achieve a partial pressure above 60 millimeter mercury. In some neuromuscular disorders where the muscles of respiratory the respiratory muscles will be affected negatively and becomes weak are myasthenia gravis, Guillain-Barré syndrome or Guillain-Barré syndrome, brain or spinal cord injuries, polio, myelitis, porphyria, and botulism intoxication. All these are reasons for neuromuscular disorders where there is weakness in the muscles that lowers down the oxygen saturation in the blood. Number 10 is impaired diffusion and gas exchange, such as cases of pulmonary edema, which is acute left ventricular failure, cases of acute respiratory distress syndrome, pulmonary thromboembolism, and pulmonary fibrosis. For post-anesthetic, post-operative oxygen therapy, it is found to reduce nausea and vomiting, post-operative nausea and vomiting as a side effect, and also reduce the risk of a surgical wound infection because of proper oxygenation. The aim is to achieve the target saturation of above 94% for acutely ill patients and above 90% for those who are at risk of hypercapnic respiratory failure. So here we have two major categories, high or low oxygen therapy concentration. So for high concentration, we said that it is mostly indicated for type 1 respiratory failure in which there is hypoxemia, but there is no hypercapnia. So here, short periods of oxygen therapy can be delivered either by face mask or by nasal cannula, and this includes cases of pulmonary embolism, cases of pneumonia, cases of acute pulmonary edema, myocardial infarction, or patients with severe acute asthma. Concentration can be very high, up to 100%, but the treatment should be for a short period to avoid oxygen toxicity. Here, in such cases, there is a lower risk of causing hypoventilation as carbon dioxide level is still normal. For type 2 respiratory failure, we usually use low concentration of oxygen therapy for 24 to 28 may be sufficient. 24 to 28% of oxygen delivery may be sufficient. And these are reserved for type 2 respiratory failure, in which not only partial pressure of oxygen is low, but also there is an increase of the partial pressure of carbon dioxide above 50 millimeter mercury. And these conditions happens during exacerbations or complications, acute on chronic conditions of chronic obstructive pulmonary disease. And the normal stimulus of the respiratory respiratory center is the increase in the partial pressure of carbon dioxide. But this hypercapnia-induced hyperventilation become blunted if the patient is chronically hypercapnic. So the patient will depend to stimulate his respiratory center will depend on the level of hypoxia and hypoxemia. So if there is a severe hypoxemia, then the respiratory center will increase the respiratory rate and maintain hyperventilation to wash off the hypercapnia. But if we deliver high oxygen concentration, this will remove the stimulus to the respiratory center to have a hyperventilation, and this will further exaggerate the carbon dioxide retention, may cause fatal respiratory acidosis. So the objective of therapy in such patients is to provide just enough oxygen to alleviate hypoxia without exaggerating the hypercapnia and respiratory acidosis. Oxygen forms an important part of medical treatment in resuscitation. Trauma, massive hemorrhage, convulsions, and hypothermia can be used as cushion care post anesthetic. We mentioned this before. So oxygen is a drug when it is delivered in higher than atmospheric pressure or higher than atmospheric concentrations. So applied properly and appropriately, it is extremely beneficial. But since it is a drug, the overuse or the abuse or the misuse of oxygen, it causes potential harm. So the aim should be always to keep the target saturation above 94%. This is to ensure that the saturation will remain 90% most of the time, even during sleep, because during sleep we expect the respiratory rate to decline, and this can lead to lower down of oxygen saturation. The upper end of the target saturation limit is 98% according to ventilation. So what are the signs and symptoms of oxygen toxicity? Oxygen toxicity, as we mentioned, can affect the eye. It can affect the central nervous system, can affect the respiratory system, and it can affect the muscles by twitching. So it affects the human body differently depending on the duration and the partial pressure of oxygen in the blood. For short-term exposure to high partial pressure at greater than atmospheric pressure, hyperbaric oxygen therapy can lead to CNS symptoms. It can lead to ocular and pulmonary toxicities resulting from the prolonged exposure at the normal atmospheric pressure. So the ocular and pulmonary toxicities are mostly at normal atmospheric pressure. CNS symptoms like seizures, even twitching, are signs of CNS hyperbaric oxygen therapy, while the eye symptoms like reduced visual field, fibrosis, these and the respiratory symptoms like jerky breathing, shortness of breath, irritation, acute respiratory distress syndrome, these are features of respiratory